Good afternoon. It is May the 13th. We are doing a special Wednesday edition of the THCB Gang. I'm your host, Matthew Holt. Normally we're on Thursday, but tomorrow I'm talking to a bunch of very, very educated healthcare executives at Columbia at the same time, so we're on today. But so I managed to corral a great lineup for today. It's a little bit similar to the one we had a couple of weeks ago. I think there's a couple of differences there. But let me tell you who's on today. From Jefferson Health System, Rajesh Aggarwal, the guy who heads up strategy and investment there, and filling in as our token Asian guy with a British accent from the Philly area this week. Healthcare It Girl, Jessica DaMassa, my co-host on Health in 2.0, and also the person who interviews more people in innovation and everybody else in healthcare. Health economist, healthy thinker, and the podcast, which I can never remember the name, Health Populi. Jane Sarasohn-Kahn coming on. Health quality expert, Michael Millenson, years and years ago, author of Demanding Medical Excellence, and these days a consultant in health quality, and long-time famous healthcare futurist, Ian Morrison at Second Curve. All right, this is the gang, so they'll be coming up right now. And how is everyone's week been? I'm going to ask you, everyone's giving me the I've got couple of thumbs up, that's good. We've just been off camera joking about the British government and how Boris Johnson sounds better in Punjabi, apparently, debating to stay in, go out. You know, it's that David Bowie song. I don't know if to stay in, I don't know if I should go out. That song, right? Apparently that's what we're doing with opening up. You can go out to have your hair cut in Texas now if your name is Ted Cruz and you don't believe in the law. All right, let's start on what we noticed in the past week. Ian, what was the thing that struck you in the last week?
Well, it actually goes back to week one when Jane was on, and I was on with her, I think, in the very first week, which is, I spent a lot of time agonizing over the jobs report. I'm happy to riff on with anyone, but just, I think there are big implications in that about the restart and the uninsured and the impact on states and on Medicaid, because when you look at the numbers, it's pretty bloody devastating what's gone on in the last 2 months.
Agreed. Jane.
So that was one I was going to talk about, but there's another one, which is that Optum Health says 1/3 of its behavioral health visits are now via telehealth. So we're seeing already people taking care of the mental health aspects of COVID via virtual care.
Raj, what do you notice in the last week, apart from the Punjabi version of Boris Johnson?
Yeah. I'll send that out as a separate webcast. Now, what I noticed was Jack Dorsey saying that anyone who works at Twitter can work from home forever, basically. And I had a meeting with my team this morning, and we were discussing that. And there's a lot of implications around that about work from home, whether it's a real estate, commuting, and so forth. So I thought that was, something that was a significant positive, but also there's some negatives to that too.
Jessica, in the past week, what struck your interest?
So kind of along those lines, but the opposite. So the Brian Solis, the global innovation evangelist at Salesforce, published an op-ed, the title of which was "Every Company Must Become a Digital Health Company," which I'm sure you can imagine piqued my interest. So I read this, and basically what he's saying is that all businesses, no matter where they're at, are going to be responsible not only for the health of their employees, but the health of anybody who comes into their business. And so how do you manage that now that managing health has to become a core competency of basically everybody in the organization? So dying to find out more about that.
And possibly dying because the people not doing it properly.
Exactly. I might never leave my house again.
Michael, what do you notice in the last week?
Well, I thought that this was a week in which we found out that technology will save us, maybe sort of, like we developed this great diagnostic test from Abbott that will go and everybody can use it, but maybe it gives us false positives and whoops. And then we've got apps all over the place from Google and Apple, and everybody's going to trace, except maybe people won't use it. And so I think this is another week of finding out that America's love affair with quick fixes and our attention span for a pandemic lasting more than, my God, one news cycle are being tested. This is going to be, unfortunately, something that has an old world attention span as opposed to a Twitter attention span.
Yeah, that's in some ways bad news for America because we don't do that very well. But we've got to hold our attention till the fall for a number of things, including the election. I have 3 quickies this week, 2 things on the healthcare blog. One I wrote about, which we'll talk more about, which is about remote care and what happens there. And in the Columbia course I've been dropping into, there's been a lot of talk about that. Second is George Halverson, former CEO of Kaiser, wrote a big piece about basically creating a Medicare for all and extending that to the entire population. And of course, the healthcare system didn't disappoint this week. Trinity Health, which is one of the biggest Catholic systems in the country, fired one of its nurses for complaining about, well, allegedly for violating HIPAA, but in fact for complaining about lack of PPE. So the good news is we're still keeping the PR reputation of the healthcare system up and above the actual reality on the ground. All right, I'm getting a lot of background noise from the fact that the schools still have not opened up here in Northern California. Things are getting tense, I tell you, for homes everywhere. So let's, Jane, I was keen to dig into that. Let's dig in a little bit, and as we have Raj on the line as well, about this issue of the telehealth, mental health sort of changes we have going on. I'd like to get into a sort of wider conversation about what we see the future of this being. Like I said, I wrote a piece about this, which Raj said he liked until I got to the last paragraph when he reviewed it. But basically, I've heard a lot about significant changes in use of telehealth, particularly from big health systems. The one I know best, I've heard most about, is MedStar in DC, with the folks at Bluestream there, who are former client of mine, who are providing telehealth for triage, said that there was something in order of a percentage-wise, it was something like a 45 times increase in the number of minutes spent. I mean, huge, just orders of magnitudes bigger number of minutes spent by their team doing triage. They were starting to do triage in the ED anyway, to things like, transplant and psychiatry. And now they're doing it for everything, everywhere, and they put the entire system on it, trained thousands of staff, immediately. I suspect that something similar has happened at Jefferson, Raj. So Jane, just give me a sense, you've been looking at this for a hell of a long time. Give me a sense of how you think the adoption of telehealth for both mental health and regular care has gone, and how quickly is the infrastructure that Jess talked about a couple of weeks ago starting to catch up?
Mm-hmm. So one thing that has happened to me in looking at this just in the last 8 weeks, and Raj, I'll be interested if this has been the experience at Jefferson, but 3 new surveys came out in the last 2 weeks. I wrote about 2 of them yesterday. And that's that a lot of what's driving consumers toward telehealth is access, yes, but it's really safety and people conscious of their own risk management, exposing themselves in an emergency room, in a doctor's office, in a hospital setting to the risk of virus. And this word safety has really come out in the last couple of weeks for me as a new kind of mental ethos in the patient. For physicians, of course, it's also to manage risk of exposure for them, their staff, and other patients. But it's fascinating to me that this is one of the sort of Maslow hierarchy basic drivers of safety toward telehealth, not just access to service. So there's sort of a double whammy there, or a double ethos. Telemental health now, looking at that, this is the new black now. This is the pandemic after the pandemic that I talked about probably when I was with you and Ian earlier a few weeks ago. And now most people are saying, yeah, I'm already quarantine anxious. We can see anger. I was at a UPS store a couple weeks in suburban Philadelphia where someone went absolutely postal. And I don't say postal to be punny at the UPS, but somebody went nuts in the UPS store and didn't social distance, and it caused all kinds of problems. So I'm hearing that from Susanna Fox in Washington. She's going running in Washington, D.C. People aren't getting out of her way. Margaret Laws in Marin running. This is coast to coast. People are kind of getting anxious. So telemental health to the rescue in getting people access to care. And I was just impressed with that Optum statistic that 1/3 of their telemental health visits are now, their mental health visits are now telemental health. So I think this is going to become a new normal. As we know, and I've wrote about this for California Healthcare Foundation a few years ago, the online couch was the report that mental health resources in America are so under-resourced, rural, urban, too expensive. Now, remember also Walmart is starting to offer telemental health in its 2 clinics in Georgia, the new clinics, for $45 for 45 minutes. So we're going to see all kinds of different flavors of telemental health, from retail health to health systems. So Raj, what are you seeing?
Yeah, so seeing the increases in telehealth across our system. Just to put this into magnitude, we were doing 60 to 80 telehealth visits a day across our enterprise. It's a $5 billion 14 hospital enterprise. And now we're around 3,000 visits a day. So you can imagine the amount of infrastructure that needed to be taken on board to do that. I think, you know, that's all well and good, and I think it's great. What I'm really interested in is, and probably if I can put this into a context, are we going to waste this opportunity for change? Is this going to be like a New Year's resolution where we're going to say, oh yeah, that was great, and then it kind of quickly dies off, or even slowly or moderately dies off? And part of this is around, you know, we're starting elective surgery. I've been doing in-person clinics last week, this week. We're going to start surgery ramping up next week. And quite frankly, a lot of what I see in the media is the new normal, the telemedicine, the being able to practice across state lines, and other approaches. What I'm really concerned about is 2 things. One, we're going to limit this kind of scope of innovation that's happened, that's been literally put in front of us. That's the front and center. And then the second piece is, if we're going to commit to the new normal, then we need to get rid of some of the old, right? So if we're going to be doing 3,000 telemedicine visits a day, and we don't need as much office space, we don't need as many MAs and so forth. So what's happening to all of that, and who's making those difficult decisions about the real estate that we have in terms of how we're doing our office visits? And the third thing I mentioned a few weeks ago was, it's actually giving patients a choice and not saying, hey, now you can come and see Dr. Aggarwal in the office next Monday, right? What do you want? Do you want telemedicine? Do you want an in-person visit? Do you want something different? And so forth. So I'm seriously concerned, more than concerned, about the opportunity that we're in front of us, and that we waste this and we go back to some semblance of normal. And this was a interesting New Year's resolution.
Can I jump in on that, Raj?
Yeah,
I think that's,
sure.
That's real important. To me, what will determine whether we go back to the new normal is a couple of things. One, of course, obviously, is the duration of this, right? And so either it will disappear magically in summer and Jared Kushner will float up into the sky and bless all of us.
It already disappeared in April. You're just not paying attention.
Which is certainly possible in Trump world. A second, as it persists and people are worried and we have a second wave and all the rest of that. So I think the duration will be important. But the other thing beyond that, and I think you're sort of alluding to it, is whether or not this causes patients to have more control of the healthcare system, or whether it's a new marketing channel for the current people. I've always been very skeptical of telehealth because I've been working on quality and safety for many, many years, as you know, and telehealth is just a way of, like, instead of a telephone, we extend our reach of all of our doctors who are all safe and wonderful and do everything wonderful. And now we can bill people all over the country or all over the state as opposed to just locally, right? And so will this enable, when we have more portable electronic medical records, they're API readable like the administration is doing, will this enable me now to use telehealth to maybe check on my local doctor with a doctor in New York or California or across the city, right? And control, will the healthcare system use this as a way to allow me to choose, like you said, or is this an income maximizing kind of thing where each system uses telehealth to maximize its patient base, and as we get back to make up some of that money that we lost, right? And if telemedicine can be a means of loosening traditional controls and bringing in digital health across platforms and across geographies, awesome. That's not something which people in the traditional system are lying awake at night trying to figure out how to give us that power. So that's
yeah. I actually. So you're riffing on something, Michael, which I think is very near to what I'm thinking about, which is that. So if we've lost whatever the numbers are, you know, billions of dollars per system in elective surgery or potentially. Now, some of that's being replaced. Some of that's crying poor math because some of that is being replaced by early Medicare patients and by extra payments for COVID. But there are clearly people in the system and, running dentist office and primary care offices, allergy clinics and what have you, who've been losing out on revenue. And, we're now talking about let's open back up elective surgeries. Why? To drive, obviously some of these surgeries are necessary. But as we discussed a couple of weeks ago, I think Brian Clapper was on a while back, and he said that someone at United told him that we thought that they were now, because we cancelled half the surgeries, we were now down to the rational, correct level of care. So you go back and forth on how much we should be doing, how much overuse there was, and the rest of it. But if we're going back to the system and let's try to fill the coffers the way we always did it, this is very similar, as you said, to what happened between roughly 2010 and now, which is, or 2005 and now, which is all the health systems that Ian will go around consulting with, buying up all those primary care practices in order to, fill the beds and fill those expensive, neurology suites and get the cath lab running and all the rest of that to make the money. So the question is, are we going to figure out a way of changing how we pay and how we reward those health systems or not? Because otherwise, telehealth is just another marketing outreach tool, which may or may not get paid in a different way. And, there is a lot in what we're now bundling into telehealth, which is getting squishy. And I think, some of the things that I've been seeing has been a lot of the companies who do remote monitoring, whether it's for chronic care, like the folks at Livongo and elsewhere, or for more acute care, who are now sort of trying to build out from some of their tool sets, I ran into a company called Sentinel the other day, which was doing hypertension monitoring and is now going to do everything because it's got a couple of customers who wanted to do that, for COVID. Are those companies, and are those institutions, are they going to become essentially, just another outreach for the big systems? Or, as I said in a little piece I wrote, which was called the piece was called How to Do Quarantine Smartly, or How to Manage Quarantine Smartly. It was coming off a piece that had appeared in the Times much earlier, which is about, could we put people in hotels to do smart quarantining? And I was saying there's a whole bunch of things that you need to put together, starting with, the ability to access remote monitoring, the access to telehealth, and whether it's synchronous or asynchronous. Thirdly was, can you get staffing? Because you only need to deliver people and stuff to where the hotels or the homes or wherever they are. They may need actual nurses visits. Hey, I had a visit yesterday from a notary because I was refinancing my house. We all wore masks and, maybe something similar is needed in healthcare. And then you just start thinking about the data underlying it, putting the data stack together to bundle all that information in one place. It doesn't really happen yet. I'm going to ask Jess in a second about what Judy Faulkner said yesterday, because Judy Faulkner was talking about doing some of the stuff that Epic was starting to do. And then, the next two pieces you need, and this is where Roger's going to disagree with me, is you're going to need somebody to actually, run the analytics to figure out what happens next and what we do about these people who we're now tracking, whether they're for chronic care or acute care. And then finally, someone's going to figure out how to pay all these different pieces which we're putting in place, whether it's staff, equipment, monitoring, whatever, and there's got to be a central place, or else we're back to where the healthcare system is now, where you go in for a surgery and you get bills from 19 different people because, 19 different people had their finger in the pie. So I think we have, so that's a not great summary of the piece I wrote. Please be watching this, go read it on the healthcare blog, because hopefully you'll find it provocative. But I'm really trying to figure out, is there a new organization that can come up and take over this whole oeuvre of activity, and are we going to have this activity, or as Michael said, is it just going to be more from the current players who own the system? We're going to do what they're doing, but just doing it with a bit more telehealth. Jess?
What do you mean by a new organization to come and oversee all of this?
If you're an old
private public partnership, what do you mean?
I don't know what it is, but if you're an old cynical man like me and some of the others on the line here, you will tend to believe that the typical American hospital system is a profit maximizing organization, which has been very good at figuring out how.
Old man, and I believe that.
Yeah, we all believe that. You're not even old cynical one. Okay, and that if you say, and that if the goal is we're going to try and create some kind of system that monitors and manages people in a kind of Dartmouth manner of getting them the appropriate care they need and not more care than they need, and managing them in their home, allowing them to be self-actualized patients managing their own decisions, all the kind of good stuff that we talk about in Society of Participatory Medicine and elsewhere. I don't believe that the current actors really have got it in their DNA to do that. And Raj may disagree with me, Jefferson's kind of unusual place, but the typical, if you look around Northern California, the typical hospital system here has just settled with the Attorney General for overcharging for the last, 15 years, was it, Ian? So they're not, now, are health plans ready to do this? Maybe the Kaisers of the world have got the pieces in place and can do this, but there aren't that many of them. So is there going to be a new organization which could manage, and maybe it's Amazon, maybe it's a startup, which could manage this entire piece? And if we're going to have, if we don't build those and have them come out of the ground now, then we're going to be back with, Sada, Mercy, Trinity Healthcare, running healthcare the way it is today.
So wasn't that the purpose of the Amazon, Berkshire, JP Morgan, that they were going to manage all this? And it wasn't obviously based on your blog around quarantine. And I'm actually just thinking back, surprised no one mentioned that as what happened this week, because that's pretty big news. So I just realized.
Is it big news? It's like the big news that never was, and that's the big news.
Let me pick up on
those of you paying attention at home, the big news is apparently it's all good one day.
Let me pick up what Raj said for a moment, because if you stop and you say, okay, follow the money, right? And it's great to talk about consumer empowerment, but we know that consumers tend not to want to pay for a lot of things to do with healthcare, right? And that's why the direct-to-consumer websites didn't do it. So if you look at the telemedicine trade association for a moment, you might think these are the folks who are going to, upset the apple cart. We're going to have true transformation and all the rest of that. But their customers are, by and large, healthcare organizations now who want to increase market share. So what's their motivation to speak up for the consumer? And you can go down the road there. Now, if in fact the Haven with the Buffett and all the rest of those guys was in fact a powerful organization that would organize employers, plans, and others to be the payer for their employees, for their consumers, to help, break up the monopolies that we have now. So what you said, Jess, about Salesforce, they all got together in the powerful, employer community, said, we're going to be the ones who are going to put our economic muscle behind it. That would be great. Having worked for an employee benefit firm, the people who choose to be employee benefits managers, second choice was not fighter pilot. These are risk-averse individuals. And, while in theory they would be doing this, in fact, if you go to your average corporate CEO and say, what's your relationship with your mega health system in your city? A, you want to be on the boards that you and your wife can go to the annual charity dinner, or B, you want to fight with them. Well, we know what the answer is. And so that's part of the problem, is you have a power imbalance here, where what all of us think should happen to empower the consumer, who's going to bell the cat, who's going to pay, and it's a pretty big issue.
So we're not going to get now,
I like that,
spammed by fighter pilots who are now in HR.
I was going to say, this is one of those reasons I found that article by Brian Solis from Salesforce so provocative, because I think, like, if you start to think about all of these other businesses really focusing on healthcare in a different way, instead of it being something that's thought of by the benefits admin person as like a benefit of employment, if it becomes an essential job function all of a sudden, and you have new people responsible for sourcing in solutions, and they're looking tech first, this could look very different. And it could be a bottom-up kind of innovation. I understand what we're saying too about incentives being aligned, and the folks that I've interviewed from telehealth companies and digital health companies who are gaining traction now, that's like the linchpin here, is what's going to happen with the incentives, because we're in a situation right now where it's like, it's a false situation creating demand. I mean, people don't want to go for safety reasons to a physical location for healthcare. And then also you have reimbursement at parity, which you never had before. So as soon as that's lifted, what happens? And I've heard everything from nothing happens, the genie's out of the bottle, people are going to like the convenience of it, they're never going to go back, to the other side of it completely, where it's like, the telehealth component of it becomes commoditized. It doesn't matter who you get your telehealth from. What's going to end up happening is that it's going to be almost like Wi-Fi. It's like whoever you get that from, there's a set fee, there's a channel, but it's going to be what kinds of things are layered on it, and those are the companies that are going to win big.
Well, it's a tool, right? I mean, it's like saying it's a shovel, and the future is about shovels, right? Well, yeah, what are you going to do with them? I mean, Raj and I had an offline.
There's a shit joke here somewhere. I'm sorry.
Raj and I had an offline conversation after last week or the week before, and I think it comes back and it connects to the Halverson story as well, right? I mean, which is, and Michael nailed it as always, that where's the money flow in all of this? But it seems to me that there's a one-time opportunity to leverage these tools, the shovels, to redesign care processes in a better way, right? And that work needs to be done. And if it's just simply bolting, adding shovels onto the existing stuff, that is not transformative. I mean, it's helpful, and it's, as you said, Jess, it makes people feel safe at least now, but that isn't changing the game.
Can you not add a shovel to the 1964 Chevelle that your ride has been pimped on?
Chevelle.
If you haven't read the Ian Morrison Pimp My Ride from 2003 or whatever.
Yeah, it's a long time ago.
Ian, I completely refer to your thesis of the Pimp My Ride, absolutely, that there's these shovels and there's more of these point solutions. My question is, though, who's going to do this work? Who's, Jess, is every major company going to have a chief health officer sitting out in the boardroom? Who's driving this work, or is it going to happen organically?
So, Raj, I would say that, and again, from having spent some time playing Don Quixote with major corporations, benefits managers, if you take a look at who's been the most successful, who will bell the cat, it's when you get physicians leading. So if you look at GE with Bob Galvin, what he did, right? Bob is a physician, smart, had the ear of the CEO, whereas most HR managers, if the CEO says hello to them in the men's room, they go home and take the wife out to dinner, right? And so if you have a physician who come into some of these positions, if you have people, if you were to do it, if someone like Ian, who's innovative, was to take on, right? If you have people or policy who can do this, then you'll set an example for other people. And what we need is not so much an organization from Matthew's British socialist background that clearly he wants a governmental organization to interfere with the private marketplace. But what you need—
But I mean, none of that in a country which just spent $3.5 trillion of the taxpayers' money on the private sector, of course.
Can you spell Keynes?
Going, Michael?
But that's in a good cause, re-election of Congress. So what we need is some kind of people who are not your typical people at a CEO and senior medical level to have the guts to do the transformation. If we get lucky and we get those kind of people, I think, leadership, we can succeed. And that's where we have to have a challenge and a little bit of luck, I think.
So let me ask you a bit about George. Okay, go on, Ian, and Jane, then I'll change topic.
Well, but I think Raj raised the right question. Who's going to do it? And I'll give you three possible candidates. It could be some kind of coalition of big tech. And I think, Jess, that's what we were driving at with everyone's going to be a health company, that they get interested, but they've also shown an ability to lose patience and move on. That it certainly could be plans, and United being the most obvious example, but I think all of those who are bet the farm on Medicare Advantage and managed Medicaid are capable of leveraging this. It's not our friend. I noted, Matthew, that the CAPG conference probably didn't take place, but our friend from Babylon was going to be the keynote speaker. That I thought that was a sort of an interesting deal. But I think do not count out, and this is the reason I've spent most of the last 20 years working with large health systems, is they have the incumbent clout to transform the game if you can redirect them. The problem is redirecting them. And the bait, and this is what I sent George Halverson a little note this morning because I did love the piece, but the bait is the money that comes from self-insured employers. And I've got an opportunity to meet with the PBGH folk in a couple of weeks. They just reached out at their board meeting. And I'm going to try and make that case that now is the hour. And they're very, the PBGH crowd are very interested in transformation, starting with primary care. To your point, Michael, about doctors, I think that's the key thing. If we can inspire groups of physicians to do this, but I'm still cheering on Raj and his colleagues in the big systems who are enlightened, who are trying to change the game. But
well, I take that. Sorry, Jane, please.
No, this is just to close the circle on this. So to Michael's point about how long will this last? How long will a recession last? And how much economic development are we going to see to come back in 2021, 2022? And will the Treasury function be there to pay the $3.5 trillion? Because I don't think we're going to come back as fast from all this. And employers, some will do well through this, but many will not. And the government can only bail us out so much in the US anyway. So I think that's the other part of this. To Ian's point about self-insured employers, some will be very keen to figure out how to do workflow differently in a lower cost level with Michael's quality in mind, right? And partnering with these tech companies, because it's going to be collaborational. I mean, the health systems can't do it all themselves. I think your point about Salesforce is good. They're going to play and they had a piece this week on a chief health officer role being the new thing. So I think it's all of the above, collaborating. And I think to Ian's point, it'll be employers driven by the macro economy that I think is going to be very slow to come back.
So let me interrupt and say two things, and I'll come back to you, Raj. But one, that I want to tell you what. So what George Albertson said in this piece, you haven't read it, was he called it medical advantage for all, but essentially taking the Medicare Advantage structure that exists of privatized health plans, extending that to, he didn't say it explicitly, but to the current Medicare fee-for-service system, and extending it to all employers. He wanted to leave Medicaid separate, which I'm not sure I agree with, but but basically making that the big driver, and having all these Medicare Advantage plans therefore pay a capitated rate out to the health systems, which gave them guaranteed income, but also then able to put into place all the kinds of things that Medicare Advantage, well, in Georgia's my Medicare Advantage, but I think in reality Kaiser did a lot better than everybody else, which is managing bed sores and managing mental health and not doing excessive care, et cetera, and then sort of spreading those kinds of analytics tools out. And that could be a vehicle for the kind of stuff I'm talking about managing care where it should be, across the spectrum of care. So, he said that, and then I want to go back to something Ian said, because, this is something when PBGH had a new CEO, I got a call saying, can you recommend a few people? And then Mary Beth Sharp, the COO, actually took me out to lunch, and she said, well, why don't you apply for the job? And I went, me? What are you talking about? And so I said, look, the only reason you could do this is, could you really do what Haven said it was going to do? Could you create an entire new system, which would be a kind of telehealth, nice +1 medical plus, mental health plus whatever thing for basically the minorly acutely ill, really go after what you do, sort of reference pricing and narrow networks for the very sick, and then build a chronic care management system a la Livongo, Marta, +++, and could you enforce that on the employers, get the employers to actually buy in to enforce it on their employees? Because if you can't do that, none of this stuff's going to matter. And she got very enthusiastic about it. And I talked to David Lansky, the outgoing CEO, and said, any chance that, the Walmarts and the Boeings and everyone else on your board would really go for this? And he went, no, don't bother. So that may be one of the many reasons I'm not the CEO of the PBGH. Right. But it strikes me that, whether it's my cack-handed idea for what the employers should do, or Halverson's idea for what expanding Medicare Advantage, either one of those is going to need massive, decisions from the employer community and the political will of, who wins the next election to actually roll this stuff out. Because this is massive change we're talking about. And it's not just, wouldn't it be nice to happen? It's going to need really serious change in Medicare, Medicaid, the tax code, and everything else gets done. It's basically another bigger Affordable Care Act. It's more than that. And yeah, we're seeing that Trump's getting hammered in the polls and Biden's looking good and all the rest of it. But I don't see anything coming out of the Democrats saying, oh, we're going to completely change the healthcare system, other than we're going to kind of, make sure the people who get covered. Right. All right. Ian, can you Raj, pin on that, and then Ian.
Yeah, no, I just want to go back to the earlier discussion, which you just summarized really well, that Jane and Ian were talking about around the different players in this. And, I think it's two levels, and you guys all know this, but it's at the vertical level where you've got the big tech, you've got the payers, you've got the providers, the health systems. They've got to come together. It can't just be one. And so my question was somewhat rhetorical. So it can't just be one of those. And then it's got to be at a horizontal level where, I guess Haven was trying to do that for the big companies, but then the health systems, how are we coming together to do this? And then the kind of the part of this that is disappointing is that as the healthcare systems, Jefferson as well, we're innovative, we're forward thinking, but at the end of the day, we're losing money and we need to get back up on our elective surgery, our diagnostics and all that kind of stuff. So that's where we're putting the focus, right? So we're not taking our eye off the focus around innovation and partnerships, but at the end of the day, we've got to have enough gas in the tank to run the engine, right? And so that's where my concern comes from around, how are we, if Treasury is going to give us the 0.2 trillion and going to say, hey, that's okay, you can pick this up, then that's a different matter. But right now, I don't see that coming very quickly. So the challenge is, how do the health systems, even the innovative ones, not say, well, we just got to go back to some of the traditional model because that's what, puts money in the bank, right?
Yeah, I couldn't agree with you more. I think that, it's something, the game is played, that is my little note to George, the game is played by massively overcharging commercial insurance relative to the cost of care. Right. That is the game. And changing that game is very difficult unless you're going to have Apple and Facebook volunteer to give you 20% of payroll, right? Which is a big number, right? When the average age is 12 and all they get is acne medication, for God's sake.
Question, how did that change? Do the economics of that change though, Ian, with what you were saying at the beginning? When you look at what's happening with the unemployment rate and the uninsured rate, is there a point where that starts to tip demand for some of this stuff? And instead of looking at those large employers that are, maintaining robust businesses in this, some of these tech companies, Amazon, Walmart, some of those, if the rest of the employers are, those businesses are shuttering, their people are becoming unemployed, is there enough critical mass then to tip it?
Yeah, well, I think the crisis is going to be there, Jess. I think you're right. I mean, it goes back to what I think both Jane and I felt was the big story of the week with the jobs numbers, right? Yeah. I'm actually playing golf tomorrow with a friend of mine who's the.
You're allowed to do that?
Yeah, we are now.
Are you wearing a mask? I'm just checking.
Yeah. He was CEO of the largest staffing company in the world. I was on the board of a competitor, much smaller. But so I've been a fan of the B1 report every time it comes out. So I spent a little bit of time, and riff with me here, Jane, but going through the combination of the last two jobs reports. So February through April, 2-month period. In that 2-month period, we lost 22.1 million jobs. 6.3 of them were in hospitality, right? Accommodation and food services. And almost all of that is bars and restaurants, right? Travel related services were only down 140,000 or so. That's before all the airline furloughs, because airlines have gone to 90, have lost 90% of their business, right? Retail dropped 2 million. Temporary help, which is only 3% of the labor force, lost 1 million jobs, right? On a 3 million base, or 900,000, sorry, I'm exaggerating. And then the big surprise was healthcare. Where you had 1.5 million jobs. Dentist office employment is cut in half in a 2-month period.
Let me give you one anecdote, Ian, before you go on, which is that, so my chiropractor, who's in the Embarcadero Center in San Francisco, is down. He's still going, but it's a big practice. He's down 60%. He told me that in the Embarcadero Center, which is a big retail center and office center downtown San Francisco, which is a massive center, he said 85% of the companies there, the retailers, are going to break their leases.
Right.
So the retail chiropractors, obviously, DeWalt Medical and Taylor, 85% are going to break their lease. I mean, that's in a very rich, ritzy neighborhood of downtown San Francisco. So I mean, it could be much, much worse, which gets to Jesse's point. Michael.
Right. No, I mean, maybe I was poorly articulating my question, but it's just does that, so if the way that, Ian, you were saying, it's we were the game is played by maximizing commercial insurance, right? But it's so if all of these, if the way that system works. It's upended by the fact that all these businesses are closing and there aren't a dearth of large self-insured employers. And that isn't the way that it goes anymore. Is that enough to tip the balance in terms of a transformation of how we pay for care?
So let me be a little bit more conservative, as it were. If you take a look at Mitch McConnell, just came out the other day saying that this $3 trillion Democratic proposal, giving money to states and all the rest of that is, terrible and all the rest of that. McConnell is up for re-election this year in Kentucky, which has hardly been, immune. Why can he come out with something like that and be immune? Why are other folks immune? And if you go out, the conversation we're having, this can't go on, there needs transformation, all the rest of it, that's great. But if you go out to the places where we need the change to happen for the political balance of power to change, are people in Tennessee and Kentucky and Nevada, and are they saying, you know what, Medicare for all isn't socialism? Are they saying my healthcare needs to change? Or are they saying, you know what, I want to see my doctor in person once this changes. If my healthcare system, if the doctors in Atlanta or whatever say better this than socialism, what will people say? And we learned from the Affordable Care Act that even though there were absolute falsehoods told about it year after year after year, the people in the red states, the doctors, the hospitals who knew all this stuff was nonsense, did not react, did not correct the falsehoods. And politically, you had a huge backlash that was completely unjustified by the facts. And people who were benefiting from the Affordable Care Act were like, our joke is get the government out of Medicare, right? But it's not a joke. And so when we talk about the inevitability of transformation, we talk about unemployment will cause this, that, or the other thing, the people who are out of work, the people who are being hurt, how do they perceive the context of what's happening to them? And I remember when there was some sort of coal mine disaster or toxic spill somewhere, and they sent the reporters out there, and the people who it happened to were not in favor of more regulation, right? The people who are suffering. So I think that while I buy into a lot of the logic of what we're talking about today, before we think that, we're on the cusp of transformation, I think we need to sort of have some idea of what some of the power centers of this country in politics and in money that are not on this call, would say. And so I don't want to be a downer, but maybe a dash of red state realism.
I invited Mitch McConnell and he wouldn't come. I don't know what.
Yeah.
Ian, you were about to make a point.
Well, no, I mean, Jess raised the right point, I think, which is where's the pain point? And right. Michael, I completely agree with you. I'm not forecasting that we are going to take this opportunity. I think the game is going to try and restart. But Jess's point is right. I mean, RWJ funded the Urban Institute to run some numbers, and they're basically saying somewhere between 25 and 43 million people could lose their insurance, and that could be over some considerable period of time, like a 2-year period, and that's pretty consistent with what Health Management Associates did a few months ago too, or a few weeks ago.
Wait till those people see how expensive Cobra is.
Right, no kidding.
And then wait until they see, after that runs out, what's left on the exchange. I buy exchange.
By the way, wait till they see, we haven't even talked about the Republicans being held responsible for consumer-driven healthcare with high deductibles and high copays. I mean, nobody has come out and said that. They, said, so excuse me, if you're waiving copays, for the emergency room during COVID, why do I have a $1,500 deductible for going to the ER during normal times? It's right. Okay if I die of a normal disease, but not a pandemic. So, the question is will we have a pushback against some of these things, or will we miss the political moment to have a revolution?
Yes, right. People love revolution, Michael.
Going for the revolution.
Ian, can I ask in terms of the demographics, do you have any idea in terms of the demographics for those 22.1 million? Like, were they the ones, and the reason I'm asking this from an insurance, from a payer perspective is, right, were they the ones, the low paid earners who weren't using healthcare and were paying into the health plans, or was it a different demographic? And I think that kind of goes to Jess's question earlier around how is this upsetting the balance in terms of who's paying for healthcare, at a broad sense in terms of into the payers, and then who's actually using healthcare, because that's always been, I would say, certainly within health insurance plans in this country, a very fragile relationship.
Right. No, I mean, you're right. I'm somewhere in my deck of stuff here is that the top two occupations who are uninsured, it's the inverse of what you asked, Raj, but
Right.
are line cooks and waitresses, right?
Mm-hmm.
I mean, those are the people that take the early bus are disproportionately uninsured, right? And so
To that point, it's more women than men, and economists are calling what we're going to enter a she-cession. It's going to hit women harder than men because those line cooks and healthcare workers
Right.
and are more women than men. So we're going to see a new kind of death of despair that'll be heavily female in the next year or two.
If I'm an actuary at a health plan, how am I dealing with that in terms of I've got these fixed costs I have to pay for all the care for my members, right? And then I've got reduced employer contributions coming in. It seems to me that if it's the line cooks and the waitresses, they probably weren't the ones that were with the chronic diseases and spending the most in healthcare, right? So it's going to be, from a health plan perspective, this is just me speculating, there's going to be even more squeezed in terms of how they spend their money. Is that fair?
Well, I mean, the short run, they're getting windfall profits, right? I mean,
Right.
Millman did an estimate somewhere between 50 and $500 billion total health expenditures will be down this year, just simply because of the elective hiatus. It's a massive effect. But Raj, I think you're pointing to the bizarre connection between who pays the bill and who actually gets services. I mean, I remember I was on the board of the California Healthcare Foundation, and the German Minister of Health decided to pay a visit, and she didn't speak much English, but her handler did. So Mark Smith, who was the CEO, asked me to come over and sit and kibitz with them. And Mark and I were trying to explain how the American system was financed and the fact that some hospitals were charging $300 and of Medicare, and she said in German the equivalent of what the it's the only, I don't speak German, but I understand.
Why don't try? You can translate it. So we've got a question on the chat which I think is worth answering. I don't know it off the top of my head, which is apart from the military, the VA, government employees, which is about 10-15% of the population, what share of the population is dependent on job-related healthcare? Because there's a bunch of people who are dependent on it who are not in the employed population, but are dependents. A lot of them, especially the people taking the early bus, as we discussed, if they have healthcare at their work, they don't usually have it covered for their dependents as well. And there's this messy stuff for kids under 26 on their parents' plan, essentially being subsidized by their parents' employer and all the rest of that.
It's
so do we know what that
153 million people
have
employer-related coverage, yes.
Okay, and we think that somewhere between 20 and 40 of that are going to lose their coverage. So
right,
somewhere between 15 and 30% of that is going to be gone. And then, of course, we still have 15 states, 12 states that didn't expand Medicaid.
Right.
And we're talking, hearing rumbles in Georgia and Florida about this happening. And some of them have slowly done it, like Utah and Wyoming, and what have you. But the big ones, Texas and Florida, haven't done it yet, right? So, I mean, I am, I'm with Jess. I'm on the barricades. I think that when this winds through, if we don't put the line cooks and the waitresses and the healthcare workers back to work pretty damn soon, I'm talking, June, July. If this drags on as it will for the fall, and then the airlines never come back, or they don't come back for 6 months or 12 months, it seems to me that the PPP thing, which I finally got my little contribution for. Thank you. So the healthcare blog can keep going for another, keep the show going for another few weeks, right? That is supposed to be, you're supposed to spend the money in 2 months after you got it. Well, most people now have got the money, and they, and people are trying to figure out how they haven't, if they're a florist or a bar, they haven't even figured out how to open up yet. So how do they even start re-employing people and then spending the money? So, they may not be able to get that loan forgiven you know, if they don't do it within 2 months. So that's a struggle. I mean, my employees are virtual, so that's fine, but that's a struggle for most businesses. And I think we're going to, you know, this is going to, as we're talking, if this goes on for a long time, as you said, Jane, the impact on people who are trying to figure out that I now, despite all the Affordable Care Act and all this great stuff, I don't have coverage, is going to continue on. And you know, somewhere in there is November the 3rd. Is that the right date? The election date, I think.
That's right.
3rd, right? So to me, that, you know, it's not a wild card. I'm with you. It's very hard to change the system. It's very hard to change the incumbent powers in healthcare. It's very hard to change people in the red states. You're right, Michael. But, you know, if we're going to get a change, it seems to be lining up with this slow or no recovery that we're anticipating. And then if we get a second wave of the pandemic, you know, happening at the same time, that puts the healthcare system under strain and puts it back into this mess again, which, you know, we're not out of the first wave yet. I think that, you know, you shouldn't discount the potential for the big change.
Right. And Matthew, on that point, I mean, I've been playing with these little scenarios, which are not quite ready for prime time, but one of them is what I would call social insecurity, whereas a major sea change in exactly the pattern you talk about, where you have 40 million uninsured with a bunch of people who are permanently unemployed because you can't open a restaurant really and make money at it for a year. And that is a kind of a questioning of capitalism that goes on that's quite profound. And that even in red states, to Michael's point, that it overwhelms and you get a kind of democratic sea change towards a more of a welfare state.
Raj, you want to
so let me just give a reflection, not from the US perspective, but from the UK perspective. So what happens in the UK is we pay national insurance. So anywhere from, I don't know, it's like 10 or 11% of your salary goes into the national insurance part, and that's what pays for health and social services, right? So if you've got, I don't know the numbers for the UK, but let's take the numbers that we have here, 15 to 30% of the people that were employed that aren't going to be employed. Well, there's two ways to look at it. One is that there's less money in the pot to spend on healthcare. So the non-essential services, you're back to waiting 18 months to have your hip replacement done. And, you know, there aren't enough nurses on the floors and so forth, right? Well, the other thing is you raise taxes, right? I mean, that's the UK, pretty simple kind of how we do stuff. And, you know, how does that reflect on, you know, the politics of the US and a coming election?
Well, I mean, you know, you're going to see, and there's a lot of discussion about billionaires giving away money in charitable things, but you're going to, you know, we've been talking about inequality in the US for a long time. The inequality that we've seen here, both in how the pandemic has affected people of different class, different race, and different ages, has been massive. You know, that's coming out of the story. And then, you know, the inequality of how nice middle class people like us can sit at home and do our work, you know, from our bedrooms or our home offices, whereas people, the line cooks, right, are out of a job. And we haven't really sorted through that yet. But as we do, I think it's going to become very apparent. And it's going to be tough if Biden wins, which I think we've got to assume at the moment it's looking in that direction, given how screwed up Trump has been for the pandemic. I know that nothing is certain in American politics, but you're going to have a lot of pressure from, you know, from the left and the center of the Democratic Party to do something big here. And his natural inclination to not do too much, I think, is going to be well. It depends who, you know, who comes with him. So we're doing a lot of speculation, but my sense is that you've got to do that. And we do have, you know, a system here where if you run a hedge fund and you get, you know, you make your money in dividends, or you're a Walmart owner, one of the Walmart families, you get paid in dividends, you pay 15%, and the secretary pays 35%. And, you know, Warren Buffett's been talking about it for years, and maybe it's the time to do something about it. Because I think Ian said this a few weeks ago, there's no way looking at the end of this that we come up with, you know, a smaller government share of the economy. We have to come up with a big government share. And as you said, Raj, it's going to be paid for somewhere, somehow, and eventually the Chinese will run out of money to give us. All right. Michael, one quick point, then we have to wrap.
The irony, just one quick point on this, though. The irony is, I mean, even pre-COVID, I was of the opinion we'd see a lot of pressure on Medicare Advantage for more. But the irony is, in states like Colorado, I mean, the Colorado governor has pulled his proposal for a public option, and largely because it was going to be done in that state on the backs of hospital price controls, right? Effectively, and it's not the time to be doing that. Although there is rumination among certain economists that this is the time to do administered pricing of some kind. So we'll see, but it will depend on the politics. And I'm kind of with Michael that don't underestimate. I was of the opinion Trump was going to get elected based on what happened with Brexit in the UK, and Boris is sitting there. And when I talk to my Scottish buddies from the Labour Party, they're all saying he's in there forever because the Scots are so screwed up and obsessed with nationalism.
I mean, we all grew up thinking that we'd settled the question of government stimulation during the Depression, right? That Herbert Hoover was thrown out of office because he stuck to these conventional economics. FDR came in, rescued the economy, right? And the voters forever after blamed the Republicans for not doing stimulation. Jane's the economist, she knows, right? And even that has now been. So the question is, those millions out of work without a safety net, are they out of work because the capitalistic system failed them? Or are they out of work because a malicious Chinese government let something out into the world that screwed us up, and we're going to put sanction on them, and maybe we're going to go to war, and I'm the guy who can make America great again, and let's not let those socialists distract us when what we need to do is combat the Chinese, and by the way, maybe the Iranians too. And that's—
Why don't you ask China?
Right, exactly. So things that we thought were the rules of the game are not the rules of the game under this president or this people. And so, don't underestimate the ability of the Republicans to play dirty and the Democrats to be stupid. So hopefully none of that will happen. And hopefully, reason and science will all prevail, and we'll be talking about, what to do with the Biden administration. But I just worry that, things that we think were settled questions economically, as Jane knows, in other ways, are no longer settled questions.
No.
All right. So I'm glad we.
The good news is Biden will get elected. The bad news is he can't leave his basement.
Government from the bunker. It worked well in 1945. I like the way we started with like a happy thing about how we're going to reform the healthcare system, and Michael has us going to war with the Chinese in 55 minutes. All right, so now we're going to real quick at the end of the show, real quick around what are we expecting to see next week. So hopefully we'll prep something. I'm going to ask to start with Jane. What do you expect to see the next week?
I think more job losses, more mental health problems, more postal, and maybe war with China. I don't know.
We're going to war with China next week. Ian, next week.
Oh, I think we are going to be in the midst of a big battle, second guessing ourselves about did we reopen too soon.
Michael, next week.
I agree. Whether we reopen too soon is going to be the big mixture of questions, and we're saving the war with China for close into Election Day.
Raj, next week.
I think as we're opening up elective surgery, diagnostics, and so forth, we're going to find out that we can do stuff more efficiently because we're only going to need essential people in the operating rooms, in the X-ray suites, and that's going to be a really interesting. We're talking about workforce. We don't need as many people to be effective, to be honest.
Jess, next week.
All right. In a stunning turn of events, as we reopen too soon, the nation turns its conversation to the lack of interoperability between health data and how we can't track anybody with COVID-19, without COVID-19, and so on and so forth.
we never. Maybe I should riff on that. In the stunning turn of events, Judy Faulkner excused it all. Because she said she fixed interoperability in 2005 in the talk she gave yesterday, so maybe she's right. My other prediction for the week is that the idea about getting herd immunity and sorting out the pandemic and getting a vaccine, I think people are going to start realizing this is going to be around for a long time, and we have to figure out a way to manage it for a long time, and that is just going to starting to seep in ever so slightly. But I don't think the study in Sweden said that only 10% of the people had the virus. And the retroviral was saying that, so the 90% hadn't. Struck me as being pretty indicative that this is a long, long way to go. All right, well, that's the end of the hour. I want to thank all of you for taking part in the THCB Gang. I've really enjoyed the conversation with Rajesh Aggarwal, Jessica DaMassa, Jane Sarasohn-Kahn, Michael Millenson, and Ian Morrison. This is Matthew Holt saying that next week we'll be back on Thursday again, which, if my math is correct, is the 21st of May. Look forward to seeing you all. This will be available, obviously, as a both as a podcast for the rest of the week, and you can come back and see us anytime. But look forward to seeing you all again next Thursday, 4 p.m. Eastern, 1 p.m. Pacific, for the next episode of THCB Gang. Bye now.